It's my great pleasure to welcome Dr. George Muturi. Welcome, Dr.
Thank you, Dr. Kabinga, for those flowery words, and thank the organizers of CRRT 2020 for inviting me to give a talk this afternoon on what we face every day, renal replacement therapy in critical care. And I'm sure this morning, most of us have gone through our ward work, and we have had a chance to probably decide to start this type of modality for our patients. So thank you very much. I hope you can see my screen. I can continue. Okay, I have no conflict of interest to declare at this point in time, but I will try to go through continuous renal replacement therapy in the setting of organ support in critical care and try to discuss the principles behind continuous renal replacement therapy, aka continuous kidney replacement therapy. We'll discuss the indications, as probably you will every time in the ward round, and then we'll try to see how exactly you do a prescription and what intricacies you go through to have a successful therapy, and what outcomes do you expect, and then summarize by taking 1 or 2 points of note in our setting. This is an ICU, and these are organ support systems. And you can see a CRRT or a CKRT machine with an ECMO next. They're in series and they're treating our patient, and you can see the blood is running. And this is what we probably will be discussing this afternoon. AKI is common in ICU hospital. Close to 30 to 60% of patients get AKI. And among those, 70% may actually go on to get to require renal replacement therapy. It's important to note that many causes, and sepsis is probably the most common. And it means that once you are, for example, septic, your host responds to that treatment and you enter into ICU, you're subjected to many treatments. And when all those concussions work together, the insult and your response, you end up with what we call multi-organ dysfunction syndrome. In it, of course, you get acute kidney injury. And most patients who have acute kidney injury in critical care have got some respiratory, some cardiovascular, neurologic, and even hepatic dysfunction. So that when you're looking at them, you don't look singly at acute kidney injury. And we all know that there's always some crosstalk between organs. Organs communicate very intricately. And the only way majority of them connect is through the blood. And when we are doing renal replacement therapy, we are actually treating blood. So we are interconnecting and cross-talking between organs, machines, and we hope to get better outcome. So whenever there is renal dysfunction, there will be a secondary effect in distant organs. And whenever we are planning a treatment, we always have to put that into cognizant. And we know for many years that renal replacement therapy, once instituted in AKI in ICU or critical care patients, the outcome is extremely poor. Despite improvements in this modality of treatments over the years, this poor mortality, poor outcome has actually remained. And the question is, why is this? Why is this? For example, in this Canadian data, people who required CRRT in ICU ended up having a very poor outcome. 62% actually died. That's not very different from the data which was available way back 20 years ago. So you can see that there is a missing link, and that missing link will explain to us why the high mortality. And they found that in these patients, despite the fact that their inotropic support was reduced, they still did very poorly. And this missing link is probably because when they were given renal replacement therapy, other organs were not supported as well. And way back in 2002, Ronco and colleagues postulated that in ICU setting, when you have multi-organ dysfunction, you probably need to implement what we call organ support therapy or multiple organ support therapy. And if you do that together and support the organs that have failed, then you may have a better outcome. So there is a cross interaction between ailed organs, kidney, liver, heart, neurology, all this. When you are treating them, you must factor all in place. So for example, if you are doing liver dialysis, AD, in the background of AKI, you should consider treating that as well. Now, when this crosstalk occurs together with the organs, you have organ-organ crosstalk, organ-machine crosstalk, and machine-machine crosstalk. So you get a very complex environment. And it's not surprising then that if you addressed already kidney treatment in these patients who have multi-organ dysfunction, you will have poor outcome. So currently, we are saying that extracorporeal organ support techniques should work together in this scenario we're calling multi-organ support. So in renal replacement therapy, as a form of blood purification, there are many modalities, there are many interventions that you can do. You can either do the standard ones, and today we're discussing about the continuous. Even continuous, you should have more ingenuity in varying your treatment depending on your scenario. You can do high volume infiltration, so when you see pulse hemofiltration, you can do accelerated hemofiltration or hemodifiltration to try to match or mirror your clinical scenario. So it's important, therefore, that when we are looking at the principles of kidney continuous renal replacement therapy, we look in detail into continuous veno-venous hemofiltration, continuous veno-venous hemodialysis, hemodifiltration, and of course the drying mode of it, scarf. This is just to show you that whenever you are going to do a ward round and you are doing that, you have decided to treat your patient with continuous renal replacement therapy or continuous kidney replacement therapy, CRRT, you don't write do CRRT to define which modality you want. Fortunately now, most of the teams in ICUs set by default CVHDF, which is probably the superior mode, then you can regulate down. This is the cross difference between intermittent treatment and continuous treatment. And you look at the blood flow, mils per minute, in continuous renal replacement therapy, it is 100 to 200. But we're going to discuss that that is not usually the case all the time. And the time is usually long, 24 plus hours. And in between intermittent, we have got sustained low efficiency dialysis. It's just to tell you that this is trying to make a difference between continuous renal replacement therapy and intermittent hemodialysis. And whenever you see a chart with a blood flow, what we call QB, more than 300, then you know you are doing intermittent. If you see it below 200, most likely you are doing either sustained low efficiency or a continuous renal replacement therapy. And this is usually gently. More in detail, when you're looking at the operations of a continuous kidney replacement therapy, it works by either convection, diffusion, or both. If you are only doing a drying treatment, your patient's having severe heart failure, you just need to remove fluid, kidney function is not very bad, and cardiologists request this a lot. Then you are doing ultrafiltration, then that means you only remove fluid. Your ultrafiltration rate will be anywhere between 2 to 8 mL per minute. However, if you are doing proper treatment in very ill patients and you're doing organ support, then you're probably on the far end, on the right-hand side, you're doing continuous veno-venous hemodifiltration, and your flow rates are very, very different. And then we're going to discuss the prescription in the other coming slides. Now, renal replacement therapy, as we know, it started in the end of the World War by a German. And later on in the 1970s, late 70s, Peter Krum and colleagues actually performed the first hemofiltration in a patient. And you can see they used the right femoral artery and the left femoral vein, and the pressure in the artery drove the blood across the hemofilter. And their prescription is not different then, almost 40 years ago, 50 years ago, than what we write today. And they achieved very well, very good outcomes. Since then, of course, we have had many, many changes and many improvements in continuous renal replacement therapy. And what remains is that the mechanism is either convection, diffusion, and sometimes there's adsorption, whereby toxins or cytokines will adhere to some absorbents as they get removed. So on my left upper top is continuous venous infiltration. You can either do your replacement fluid before or after the filter. Below it is dialysis, continuous venous hemodialysis. When you have your patients who just need only dialysis, you do very slowly, and you can put, there is no replacement fluid or substitution fluid, as we call it. And the last one is the better treatment, the more expensive one, where you do both the dialysis and the replacement fluid. The replacement fluid can come before or after the filter. And the dialysis fluid usually flows countercurrent to the blood to maintain the diffusion gradient. And because of the transmembrane pressure and the ultrafiltration, you are able actually to drag larger molecules rather than only the small molecules. So the middle molecules are better cleared by hemofiltration, hemodifiltration, as compared by hemodialysis alone. And this explains the mechanism that we're going to see. Nowadays, some of the membranes that we use are coated with adsorbents that can absorb certain injurious cytokines, and that helps in the treatment of our patients. It's an actual patient connected. You see you have a central line, and you have many pumps, and every pump has a monitor, and every monitor, therefore, if it goes wrong, of course, it rings out. And that's why when these treatments are running, there are many signals that the nursing team has to take care to ensure that the treatment goes on very well. It's most of the time is automated. So how do you decide that this patient needs continuous renal replacement therapy? They have AKI, acute kidney injury in critical care setting, and the definitions are many, but AKI only in the background of multiple organ dysfunction, you may not need the classical indications to start your patient on organ support. And what are we dialyzing? Either you want to remove too much fluid, you want to remove correct electrolyte imbalance, acidosis, remove waste products, or in sepsis and other organ support, remove cytokines, or actually what this mystical world of doing blood purification, as now we're tending towards blood purification as a term for renal replacement therapy. All in this, you're trying to actually mimic what the kidney does, albeit at that or less %. And for CRRT, often the indication will be acute brain injury, or those conditions in which there is a likelihood of increased intracranial pressure, liver disease, chronic or acute. These patients are likely to have increased intracranial pressure, and they're advised to use these kind of modalities. Or people are hemodynamically unstable, where the blood flow needs to be quite low and get treatment. And this has been sort of indications that people have used to treat patients with continuous renal replacement as opposed to intermittent renal replacement therapy. Now, one of the challenging issues that you meet when you're treating patients with continuous renal replacement therapy or AKI is fluid overload. And Michelin-Mann syndrome is actually toxic. It causes a endothelial dysfunction, endothelial quality is disrupted, it induces cytokine storms, and can actually in itself induce AKI. And it's important to control fluids in patients who have acute kidney injury in the ICU or generally. And that's one of the reasons why people end up to put patients on CRRT, because the control of the fluids in CRRT is much better. What exactly will be the prescription? The reason to initiate treatment anytime, of course, is that you need a modality that is gentler, that will cause less problems in terms of hypertension, that will probably improve long-term renal recovery and reduce length of ICU stay, and probably does not contribute to mortality. Now, traditionally, as I've said, hemodynamic instability will indicate that you may need to go to continuous renal replacement therapy as opposed to intermittent therapy. Fluid fluctuations, intracranial pressure, and if you want to feed adequately, you need to monitor intake in and out, and continuous renal replacement therapy may be better. And for septic patients, then this might be better as it may contribute to removal of cytokines, although the team that advocated for that did not get good results. Now, when do you start continuous kidney replacement therapy? Or put it in a better way, when do you start extracorporeal organ support in the context of multiple organ support for patients who are critically ill in ICU? As we said, they are unlikely to have just one organ dysfunctional. They have an inotrope there, they have a ventilator going on, they have GIT in digestion, and they are not absorbing. So it is a multiple system, and you need to put that into perspective, and that's when you get better outcomes. Now, when to start treatment, renal replacement therapy in AKI has been studied recently in detail, and what comes out before April 2020 was that late or early does not make a difference. You probably needed to have better tangible. You didn't get better outcomes. And just a few months ago, the START group from Canada, from New Zealand, it was an international group, published data to show that you do not need to hurry to start renal replacement therapy. If you did that, actually even ended up with poor renal recovery in the long term. So we've said now that for you to start renal replacement therapy, you need traditional indications, and you slow down, think through them, and see whether they are available. But I want to challenge you that the background of a multi-organ failure, you may actually not need exactly and to wait for traditional indications to start organ support. For example, column 1 is a patient who's 100 years old, multiple stroke, 2 amputations, as renal failure, probably even if you started dialysis, you will not affect the survival of that patient. On the other hand, a 30-year-old cardiomyopathy with a Moturi-CRRT, you are likely to have this. But if you approach the treatment of organ support as opposed to replacement therapy, they may have a better way of making decision, and then try to avoid unnecessary treatment that, of course, are costly and sometimes may not yield much. If you start a treatment, you must have a plan of discontinuing it. And this one, Shiv and colleagues actually put a plan you can implement to try to win people off CRRT. I mean, you're trying to say that AKI has recovered. Most times, that's not true. So, but if you can demonstrate urine output and demonstrate spontaneous decrease in serum creatinine without renal support, then you probably have recovered, and this is the time you will start winning off renal replacement therapy. These patients, most of them are stable, their respiratory function has improved, they're getting off the vent, their fluid balance is better, and there is no injurious intervention that is going to occur soon. So you can actually win them out. Now, if you have to do an actual prescription, you will need to look at the substitution fluid, the outset flow, blood flow, and put them the way we have just discussed a while ago. The replacement fluid depends so much on the effluent flow rate, which is the dose, and that is in mils per kg per hour. For example, in a 70 kg person, you will get 20, that's 1400 mL per hour. So you can actually then divide that in between replacement fluid and outset fluid for hemodifiltration. If you knock out the outset fluid, that becomes hemofiltration. If you knock out substitution or replacement fluid, that will become hemodialysis. If you knock both of them away, then you're getting scarf. So what is the correct dose? People have done many studies, and it's just a cartoon to illustrate that the exact dose is not known. But now people are settling a dose between 20 and 25. Often when you prescribe an effluent dose of 20 to 25, the actual dose given will be less. So majority of people prescribe more. Personally, I tend to do between 30 and 35. Downtime accounted for, you get the delivered dose to be around 20 to 25. And that has been shown to be more better in terms of outcome than higher doses or doses below 20 mL per minute, per kg per hour. So is there a role for high volume infiltrations in septic acute kidney injury? And these are meta-analysis. And in this forest plot, you can see there was really no role if you're in high volume infiltration, where the effluent flow rate was above 50. The average was above 50. And sometimes people do super high where the effluent flow rate is put at about 100. Sometimes the only thing they do is increase the cost, waste some nutrients from the body that are water soluble. And most of the time, this treatment is not good. However, if you have got burn septic patients in septic shock and have acute kidney injury, and you give them high volume infiltration in this particular study, Shuni et al., they showed that they actually had some benefit in their hemodynamic instability. You can see that they ended up not requiring a lot of vasopressors and generally tended to improve. Whether this translated to better mortality or not was not determined in this particular study. But you can see that patients who are in septic shock probably may benefit. And this is not, this is in keeping with the mechanistic that this hemodifiltration may have taken away some of the cytokines that are injurious and causing sepsis. It's important to provide adequate anticoagulation to ensure that you preserve your filters, your lines, and your catheters. If you do not do that, then you get poor outcomes and ineffective treatment. And people have looked at heparin traditionally, and citrate was introduced in the 1980s, and later on came treatment of choice in the 90s for CRRT, regional citrate anticoagulation. You can also do regional heparin anticoagulation. Generally speaking, citrate anticoagulation is much better than heparin anticoagulation. Heparin is cheap and easily available, and monitoring is probably better than citrate when you don't have proper monitoring support. You need to do calcium frequently to determine citrate adequacy in these particular patients. And if you do not have a laparoscopic ionized calcium, then it gets quite difficult. So generally speaking, most studies are tending towards citrate regional anticoagulation for CRRT to preserve the filter, improve, reduce blood clots, and actually improve the effectiveness of CRRT. If you do not do that, then you form blood clots, lose blood, and make your CRRT quite ineffective. Now, we know that renal care is common in ICU, and sepsis is probably the most important. And you must treat that sepsis if you want to make headways. And once renal replacement therapy has been instituted, then the dynamics, pharmacodynamic dynamics and the kinetics of your drugs differ, particularly antibiotics. And you need to prescribe them in cognizance with your treatment. If you do not do that, you will have ineffective treatment and you will have poor outcomes. Common antibiotics like vancomycin should be substituted with bicofenil, especially once we started renal replacement therapy, because the latter has minimal changes in terms of dosing when you're using renal replacement therapy. And many other antibiotics, including meropenem, should be dosed adequately. For example, this morning we are on CRRT, patients on meropenem, 500 milligram TDS. You can see this one is gram every 12 hours for patients who are doing 8-hour SLED. The standard duration for SLED is usually between 8 hours to 18 hours. So 8-hour SLED, you will do 1 gram for meropenem. Now, poison can also be dealt with CRRT in critical care. Critical care patients can come having had a lot of poison, and their removal depends on the type of poison, the molecules, and their sizes. And CRRT has been shown to be effective in removing poison. The common poison that you get is actually methanol. And between intermittent hemodialysis and continuous renal replacement therapy or hemodifiltration, the removal for ethanol is quicker with intermittent, but not very far off from CRRT. And overall outcome, there's no difference between the two. So for patients who are very stable, then you probably may need to use intermittent hemodialysis. For those who are more sick, more dynamically unstable, you can use continuous veno-venous hemofiltration. Now, how about outcomes in terms of ICU stay? Many studies previously have shown that between intermittent hemodialysis and CRRT, there is no difference. But how about between hemofiltration and hemodiafiltration? In this study, there was an improvement when you used hemodiafiltration as compared to hemofiltration for sepsis. But when you got critically ill patients who are not septic, there was no difference. So most people would say there's no difference between hemodiafiltration and hemofiltration. But if you want to clear your acute indications, your hyperkalemia, your acidosis, you're probably better off putting in a diffusion component into your treatment. And that's why probably hemodiafiltration may be better. And then you do higher flows to improve that. Next, if you have got intracranial events, then you are better off using a continuous renal replacement therapy, either hemodiafiltration or hemofiltration or peritoneal dialysis. Peritoneal dialysis is a form of continuous renal replacement therapy. But since we are not discussing here, we'll keep to this. In this study, of course, SLED continuous intermittent hemodialysis that has been prolonged was shown to have no increase in intracranial pressure, mean arterial pressure, and cerebral perfusion as compared to hemofiltration, continuous venous hemofiltration in patients who are treated. So this is just to show that if you have a patient who have intracranial events and you cannot access continuous renal replacement therapy, then you can think around your available resources and treat those patients adequately. And this is actually very common, particularly our patients who do dialysis, very high blood pressures, they are on anticoagulation, they end up with neuratic stroke. And this scenario, when they go to the ICU, they are going to ICU where they don't have these other machines, or you cannot use them because of no anticoagulation. It's probably a SLED treatment. In terms of mortality and hemodiafiltration, intermittent hemodialysis, in all the studies, there was no actual difference. Particularly hemodiafiltration study, a large study, carried almost 2 decades ago, showed no particular difference. More recently, the Convin trial in 2014 showed that if you put patients into CRRT and put another group in intermittent hemodialysis and assess their outcome 14 days after stopping the renal replacement therapy, you probably will have no difference whether you put them in continuous renal replacement therapy or you put them into intermittent hemodialysis treatment. This study was well carried out and well spread out. And as I said, there was no difference in survival, in recovery of renal function, and general mortality. Now, if you compare the various treatments in intermittent hemodialysis, continuous renal replacement therapy, and the in-between treatments, then you can suit them into your scenario, looking at the costs, the duration, and try to score. For continuous renal replacement therapy, if you have hemodynamic instability, if you have got intracranial pressure, if you have got to feed very well, and if you have got to do minute-by-minute monitoring of your patient, then that's the treatment to go for. If, however, you must use anticoagulation, then that might not be the best treatment. The other thing is that it might be costly. However, when you're choosing a modality, you can use hemofiltration as opposed to hemodiafiltration and use an appropriate dose to reduce the costs and treat your patients. In the era of COVID, renal replacement therapy, prescriptions have changed. We have written many of them, and we have actually tended to overtreat, to do continuous venous hemofiltration for a shorter time, but achieving the dose you will achieve per day. 5 hours, you put very high effluent flow rates, and this is almost akin to to intermittent hemodialysis and you get proper outcome. Now, this consensus group looked at renal replacement therapy in the third world, and the goals of treatment is that you need to control quickly patients who have acute indication and treatment very well. And then you must use available tools to treat your patients. You don't have to think of CRRT if it's not available. When you're choosing a treatment, always involve everyone available and look at the risks and costs and choose your treatment carefully. If you want to track down who to treat, then you use this particular scenario. And if you're having all options, fluid overload, life-threatening conditions, dynamic instability, brain injury, hypercatabolism, then the correct treatment to choose if available is continuous kidney replacement therapy. I will end by saying that continuous kidney replacement therapy is an effective therapy in critical ill patients, and saying that it can give you time and organs time to recover, and should be treated in conjunction with other organs in mind. You can achieve your goals, fluid control, dynamic instability, and allow your patients to feed well. The modality you choose between hemofiltration and hemodiafiltration is not important. However, the dose should be calculated accordingly, and do not do it in isolation without organ support systems. Use available resources to treat your patients whenever they need kidney replacement therapy. And continuous renal replacement therapy can be part and parcel of multi-organ support therapy for optimal patient outcome, and therefore improving their long-term survival, ICU stay, renal recovery, and general well-being after a critical illness. Thank you very much.
What do you think? What do you tell them to do based on the economics, the cost of CRRT and other modalities of dialysis? Will you recommend them to use this CRRT anywhere? Or what would you tell them? Just one, and then we close the chapter.
Thank you, Dr. Kabinga. The cost of CRRT is a little higher than standard hemodialysis. And as we said, there are more equipment that are much cheaper, which you can be gotten. And then the fluids that are used can be manufactured locally to reduce the costs, or can be manipulated to reduce the cost. And during the prescribing, you can do the minimum acceptable dose so that you don't overuse the fluids, and that's where the main costs lie. They can be used anywhere because you do not need a water plant for most of them. For almost all CRRT to run, they're independent, so they are very appropriate to be placed anywhere. As long as you have a critical care facility, you probably will need a CRRT machine. But if you do not have that, doesn't mean that you don't treat your patients. You've clearly seen a little earlier. You will have to tinker with the current equipment you have to provide adequate treatment.
Okay, thank you very much, Dr. Moturi.